delay. Please put your phones on mute, and we will call for public comment at the appropriate times. We'll leave that to the chair. Can those of you in Las Vegas hear us? Can you hear us down there?
Yes.
Excellent.
Okay, and then I think one other thing for those on the phone, make sure you do not put us on hold, because then we get all the background noise of your company's music or whatever, and it's difficult to conduct the hearing. So, thank you. Do we have Dr. Klein in Las Vegas yet?
No.
Okay. We do have a quorum, so I think given that it is past the time that we were going to get started, we will go ahead and get started this morning. I'll go ahead and call the meeting to order. This is a properly noticed subcommittee for the Plan Certification and Management Advisory Committee for the Silver State Health Insurance Exchange. I want to welcome all of you here today, and I'll ask Mr. Hager if he will take roll for us and find out if we have any announcements.
Dr. Ahern?
No. Present. Sorry.
Dr. Jackson?
Present.
Mr. Finch?
Present.
Mr. Mathias?
Present.
Ms. Mayville?
Present.
Dr. Roberts?
Present.
Mr. Woodley?
Present.
Vice Chair Dr. Klein? Appears to be absent. And Chair Campbell?
Present.
We have a quorum.
Thank you very much. And Dr. Roberts, if you would, if Dr. Klein joins us, if I don't see him on the screen, would you interrupt us and just let us know that he's joined the meeting, please?
Surely.
Thank you. Mr. Hager, do we have any announcements this morning?
No.
I don't have any either. So I will turn to agenda item number 2, which is public comment. Do we have any public comment in Las Vegas?
Yes, we do.
Thank you. For those of you that wish to come forward during public comment, please remember to identify yourself for the record, and it would be helpful if you would spell your last name.
Good morning. My name is Claire Griffin. I represent the Southern Nevada Holistic Health Coalition. My last name is spelled Griffin.
Thank you. Welcome.
Thank you. I'm sorry, I'm just a little nervous. I've not done this
All right.
before.
Take your time. You will be limited to 3 minutes in testimony.
Yes,
though.
ma'am. Okay. I appreciate the opportunity to make this comment before the committee. In representing what we refer to as standalone community mental health providers, we just would like to ask the committee to think about the contribution of providers that stand alone who provide mental health services to the community in the form of behavioral health and therapeutic support. That being said, we're understanding that, simply put, the Affordable Care Act is an approved state plan amendment through enrollment and coverage that provides benchmark equivalent health care benefit coverage. So far, Nevada's response, the ESPDT Medicaid Nevada checkup will allow for prevention screens and diagnostic tests and treatment as a means of preventing or lessening the impact of a pre-existing condition. However, the scope is as typical, with much of the coverage is highly contingent still on medical findings, which do not include typically mental health status. While mental health screens are mentioned, they are mentioned as more an afterthought, since it is falsely believed that one's mental health status is non-existent in the absence of a physical basis for occurrence. And as a clinician with almost 40 years of experience in the field, I can assure you that mental illness can exist in the absence of a pre-existing physical impairment. I also know that one's mental illness can actually contribute and even produce a physical anomaly, and I cite hysterical pregnancy as perhaps the most familiar example of what I'm saying. Director Cindy Mann's report, in Director Mann's report, she graciously acknowledges the existence of mental illness within the state of Nevada and points to the importance of ensuring that needed services for individuals who may be faced with such challenges not be overlooked. However, Director Mann often in her report couples the existence of that mental illness with substance abuse chemical dependency. We do not disagree at all with her well-stated objectives and supporting evidence. However, it would be remiss not to again state the obvious, that mental illness can and does stand alone, and if left untreated, is a documented catalyst to that chemical dependency being initiated by the consumer in the hopes of relieving being initiated by the consumer in the hopes of seeking relief from sometimes agonizing impact that mental illness can have on their lives. Finally, just as we have all learned to accept that chemical dependency is a medical disease and have now elected to be more inclusive in our allowances for coverage, let us appreciate the mountain of evidence that disorders, namely schizophrenia, bipolar disorder types 1 and 2, ADHD severe, which is often clustered to co-occur with ODD, which is oppositional defiance disorder and conduct disorder, intermittent explosive disorder, and one that everyone is familiar with, major depression, chronic or recurrent type, to name a few. The exchange's interpretation to date. The focus has been on the financial bottom line, and seemingly only as it concerns vision, mental, and what is referred to as rehabilitative and habilitative care. Let me add that we applaud the state's willingness and foresight to include autistic spectrum disorders, simply because there is a large portion of the citizenry here that are primary caregivers for family members who are diagnosed with this condition and who have never been able to experience full benefit of access to health care that their neighbors enjoy. If there is ever a group in need of access to health care, it is this group. This brings me to asking the committee to please consider that when discussing the methodology of treatment that comprises rehabilitative and habilitative care with respect to mental behavioral health, both chronic and acute, keep in mind that these forms of care do not call for either speech, occupational, or physical therapies in all cases. Rather, they call for psychosocial rehabilitation, or PSR, where the focus is on helping the individual to learn or relearn how to manage their internal loci of control, which is inclusive of emotional regulation, social and communication skills. It is about basic skills training. I'm almost done.
Okay.
I'm sorry. Which focuses on assisting the individual with, again, learning or relearning those basic tasks, with adjustment to daily living, which is inclusive of restoring an individual's awareness to an outside world. Standalone behavioral mental health providers are not hospitals or clinics with labs, but they are the consumer's choice for service when it comes to addressing the aforementioned mental health challenges, as well as when seeking the methodology best suited for that care. We know from direct experience with these consumers that they make the choice to seek their services, type 82 and 14 as defined by Medicaid, simply because we are able to do provide for individualized care, and we make house calls. When you seek to lower the rising cost of health care and you acknowledge the desire to reduce hospital stays and emergency room visits, all of which contribute to the subsequent rising cost of that health care, then it is of great value and benefit to seek out your existing provider resources, particularly since transportation is no longer a covered entity within our insurance milieu. I stand before you today as representative of those standalone providers who happen in this case to make up federally funded and nationally recognized Southern Nevada Holistic Healthcare Coalition. We are comprised mainly of independent behavioral health care agencies that are approved Medicaid fee-for-service providers who have been facing a warehousing of services under the rubric of HMO providers of service, who comprise much larger corporations who are hospital-based or affiliated and are able to provide both residential and community health care in office buildings where community treatment is provided. I really do appreciate this opportunity to bring some of this information before you today, and I ask that you please consider behavioral health care and the providers who deliver that service to our consumers in an effort to lower the cost of health care overall. Thank you so much.
Thank you, Ms. Griffin. And then would you please give your written testimony to Dr. Roberts? Because
Sure,
then we
yes.
can post it on our website as well.
Okay,
Thank
thank you
you.
so much. Okay.
Do we have anyone else in
Madam
Las
Chair.
Vegas? Yes.
Dr. Klein has entered the building.
Oh, good, thank you. We'll note for the record that Dr. Klein has joined us this morning. Is there anyone else in Las Vegas that wishes to use public comment at this time?
It does not appear that there is any further public comment.
Okay, thank you. Any public comment here in Carson City?
Is this on?
Yes.
Good morning. My name is Jim Mullen, M-U-L-L-E-N. I'm with Delta Dental Insurance Company. It's a pleasure to be here this morning. I was a bit tempted to, like everyone else in the hotel this morning, hit the slopes, but it's a pleasure to be here nonetheless. Beautiful day up here today. I'd like to start by thanking Mr. Hager and his staff. I've had some informal conversations. I've appeared before the board and this committee before. We've had some informal conversations and appreciate the opportunity to talk about a focused issue of importance to us, obviously, standalone dental plans. I'll get right to the point here with 3 minutes allowed. We know that the Affordable Care Act, as it's laid out in the agenda here, allows for standalone dental. And the important component there is that the amendment that allowed that in the Affordable Care Act, we call it the Stabenow Amendment. It was the main proponent was Senator Debbie Stabenow of Michigan. Is that what it does is it waives a qualified health plan, a medical plan for those purposes, from having to include the pediatric dental component and still be allowed in the exchange. Otherwise, the ACA says a QHP has to cover all 10 categories. It's the only exception in the Affordable Care Act is that a standalone dental plan can meet the pediatric benefit, and therefore the QHP does not have to. However, and that really replicates the way the market plays today. In the market today, especially in the small employer market, the agent will bring the series of plans to an employer and lay them out, even if a medical plan covers both medical and dental, for cost comparisons. The agents and brokers will lay out the full cost of various plans, and the employer therefore has the choice to choose to match up in whatever way they feel best suits their needs, including the possibility of choosing standalone dental. So roughly 98% of dental coverage in the country today comes through a standalone dental plan. Even if that standalone dental plan is the same carrier as the medical, it still is a standard, a separate standalone dental plan. So my point in that is that as the interest of the plans that want to be in the Nevada exchange clarifies in the coming months, there may be a need for the exchange to, in some way, ensure that there is a competitive aspect to the exchange, in that if all the QHPs who come to the exchange say, we're going to cover all 10 categories, then there really is nothing to gain by having a standalone dental plan in the exchange, because the QHP is basically saying, here's the full 10 categories, take it or leave it. Now, we are not against a QHP being allowed to do that. All that we would ask is that the dental component, much as it's done in the marketplace today, be separately priced and offered, so that a consumer will have that full range of choice. Certainly they can combine the same medical and dental carrier and have one package. But they may also say, well, my provider isn't with that particular plan, and that provider is with one of the standalone dental plans. And so they take the medical portion from the QHP and the dental pediatric from a standalone plan. So that may, and our ask to the exchange and to this committee would be to think about that in a way of saying that it's some bit of engineering. I don't know that qualified health plans would be against the idea, but they might. It may increase the number of filings. I would bring that to your attention, that the Division of Insurance, if the QHP is forced to separate that may be a separate filing. But in the end, we think that the competition and the choice benefits the Nevada consumer more greatly than perhaps the difficulty for an issuer. The reason that I think standalone dental plans need to participate in your exchange and that they be viable is because they concentrate on dental benefits to a greater extent than a medical plan would. We, by nature, have usually twice the size networks that a medical plan would have with their dental component. We concentrate more on benefit design, we concentrate more on quality, claims processing, all of the dynamics that go along with concentrating just on dental and not being, having to be in two places at once. So we think that those are some of the basic reasons that the exchange would consider this kind of artificial engineering to make sure that there is enough choice in the exchange.
Mr. Mullen, that's the 3 minutes.
Okay, so
But can you stick around, because a lot
Absolutely.
of the stuff that you have to say will be very important for item number 4, and we'll probably need your assistance.
thank you very much.
Any other public comment here in Carson City? Yes, please.
Good morning. My name is Paul Wilson, and that's Wilson. And I am speaking as a small business owner, optometrist in private practice in Reno, and a member of the healthcare delivery community in Nevada since 1995. Thank you to the Plan Certification and Management Advisory Committee for the opportunity to provide public comments today on standalone vision plans. Standalone vision plans are some of the largest insurers by membership in the state of Nevada. 90% of those covered in Nevada today for vision care obtain their care through standalone vision plans. This means that only 10% of vision care presently is delivered by a health plan in our state. There are hundreds of doctors of optometry in Nevada like me that are small business owners. They are based in the community and serve rural, urban, and suburban populations. We also serve a large number of small businesses in Nevada as well. Eye doctors like me often detect signs of certain chronic conditions before any other healthcare provider records the condition. Additionally, the utilization of preventative care through a health plan delivery channel is less than half when compared to preventative care usage through a standalone vision plan. My purpose today is to express support for the inclusion of standalone vision plans in the Silver State Health Insurance Exchange. Standalone vision plans should be allowed to provide these benefits directly. Otherwise, higher utilization will mean higher costs for the state of Nevada due to lost opportunity for the earliest possible detection of chronic conditions. Specifically, I support the bill request, BDR 1285, to enable standalone vision plans to provide care in the Nevada exchanges. I would ask you to approve the requirements provided in the certification of standalone dental and vision plans report for standalone dental and vision plans. Thank you very much for your time.
Thank you. Is there anyone else here in Carson City? How about persons joining us by telephone? Does anyone wish to take advantage of public comment? Hearing none, we'll close agenda item number 2 and move on to agenda item number 3, which is the approval of minutes for October 29th. Are there any additions, edits, or changes from members?
Move to approve.
Second.
Okay. I do believe on page 4, though, we do have one correction that we need to make, and that is Whereas the 7-1 vote should be changed to Dr. Roberts instead of Mr. Roberts. So if I could have that amendment added to your motion?
Move that Dr. Roberts be given his title as appropriate.
And the second agrees.
All those in favor of the motion?
Aye.
Any opposed? Thank you.
And Dr. Roberts, please accept staff's apologies.
All right, we'll close agenda item number 3 and move on to agenda item number 4, which is discussion and possible action regarding certification of standalone dental and vision plans on the exchange. So, Mr. Hager, you want to get started?
Yes, we're going to have Damon Haycock, our Finance and Research Officer, give the next 2 reports. And I'll provide some comments here and there where appropriate.
Good morning. My name is Damon Haycock. I am the Finance and Research Officer for the Silver State Health Insurance Exchange. My last name is spelled Haycock. And as agenda item number 4, we will be discussing the certification of standalone dental and vision plans on the exchange. A little bit of background, and you've already heard it from some of our public comment here in Carson City. 42 U.S. Code 18031 allows issuers that provide only dental coverage to offer such coverage on the exchange as a standalone dental plan. Furthermore, the ACA that it must cover at least the pediatric dental essential health benefit, and that any issuer of such plan must meet the qualified health plan certification standards. Offering options, of course, can be as a standalone dental plan or, like the gentleman from Delta Dental said, in conjunction with a qualified health plan. And that sufficient capacity must exist. So the exchange must consider the collective capacity of these standalone products during the certification process. And so if a plan is offered as a standalone dental plan, that other qualified health plans are not mandated to meet all of those 10 essential health benefits, specifically the pediatric dental part. Therefore, the standalone dental plans can exist. Now, as far as qualified health plan certification standards and the applicability to standalone products, there is a report that was submitted, and hopefully those that do have it in front of them. Those that do not, I will go over it so no one misses anything. There are standards and descriptions of each subsection of the standard on a table that was provided. I believe it was also out on the website for those that are furiously trying to click there now. All these standards were taken from 45 CFR Part 156 as well as 45 CFR 155. So I'm going to go over the standards and citations that we believe are applicable. And please, if you have comment or questions or want to discuss them, slow me down because I can talk fast sometimes.
Damon, if I could interrupt before you get to that. I want to make sure that we understand what's going on as far as the paragraphs on page 2. The board approved a regulation adopted regulation in January that created fees for qualified health plans with dental, qualified health plans without dental, and for standalone dental plans. That regulation did not include standalone vision plans because we don't believe that we have the statutory authority to offer standalone vision plans. As Mr. Wilson pointed out, BDR 1285 includes a request to offer supplemental products that would allow us to offer standalone vision plans. So we intend to go back to the board and amend that regulation to include standalone vision plans once we have that authority. But we think it's inappropriate to add a regulation that is inconsistent with state statute, which is why we didn't add it at this point. That does not mean that the board has backed off from the policy decision to offer standalone vision products. The board's recommendation as it stands is to offer standalone vision products, and that BDR was part of the exchange's submission. So I just want to make sure everybody's clear. It is the exchange's intent to offer standalone vision products. We have to go through the proper legislative procedure to get the legislative authority, the legal authority, to actually set up that regulation. So as soon as we get the legal authority, We'll work on the regulation process. This board packet is going forward, assuming that we are going to offer standalone vision products. And so, because we need to make that headway today to get to the right place. And we'll discuss at a future board meeting the actual fee that would be charged to a standalone vision plan would be proportionately lower, just as the dental plans were lower as well. We have the authority to offer dental plans, even though it's slightly inconsistent with our state statute. The state statute requires that we implement the Affordable Care Act, and the Affordable Care Act says we'll offer standalone dental plans. So we felt comfortable going forward with the dental side. Again, this is the policy that we would, this report represents the policy that this committee would recommend to the board, which is so far consistent with the board's belief that standalone dental and vision products may be offered. One clarification to the vision piece, because there is no exception for standalone vision products within the Affordable Care Act. The standalone vision products would only be offered to adults. That every qualified health plan that is offered on the exchange, every medical qualified health plan is required to offer the standalone vision pediatric vision. I'm sorry, not standalone. Every medical qualified health plan is required to offer the pediatric vision essential health benefit. We cannot separate that out from a medical qualified health plan. So just so that we're clear, while we can separate it out for dental, and a standalone dental product can be offered for both children and for adults, the standalone vision plan, as we read the Affordable Care Act today, does not give that exception for vision plans. So we're only talking about standalone vision products for adults, though I think the board felt that that was important that that be included. And there was one thing that I wanted to add that has, the other thing that we have to look at that will be interesting going forward, and we might need Mr. Mullins' help on this. Outside the exchange, there is some question as to whether a qualified health plan is required to include in that qualified health plan the pediatric dental product. The concern is if it's required outside the exchange, if any plan that's offered in a small group and individual market is required to offer the vision essential health benefit, the dental essential health benefit outside the exchange, and the plans are required to be the same both inside and outside the exchange, then inside the exchange all you would have are plans that include the dental product, which would eliminate the standalone dental product. And so we're going to ask Mr. Mullins to get up here to talk a little bit about that after we get through this report. So that's setting the stage for the...
Right, and that was one of my questions, and we just put it on the parking lot for the report, is whether or not someone could be outside the exchange for medical and go in for standalone pediatric dental. Because you're right, we would have to incorporate that in our product. And once you're building a network and incorporating or renting a network for that, the average health plan is just going to say, okay, it's easier for me to administer everything all in one, as opposed to have the option of the standalone product.
Absolutely, and it's not just the ease of administration, but the requirement that qualified health plans both inside and outside the exchange be priced the same.
Right.
And so then you've offered it the same both inside and outside the exchange. So we need to work through that here, and we may have some opportunities in the future to push back on CMS to try and provide a more favorable interpretation for the state of Nevada, and so we'll work on that. So I just wanted to make sure that the stage has been set for the table that Mr. Haycock is going to go through.
Madam Chair, one other question, just to make sure everybody has the same understanding. Under the mandates, if a consumer chooses a plan that doesn't have the dental or vision and has to choose a standalone plan, are they mandated to choose a standalone plan? Is that part of the mandate of coverage?
We're not exactly sure. It is a mandated essential health benefit for children. We are not clear on whether or not that means that if you choose a qualified health plan that does not include dental, if you're required to then select also a standalone dental product that for children. Now, for an adult, you choose a plan that doesn't include dental. You don't have. We're very confident that you don't have to select a dental plan for that adult. But on the children's side, we're not sure if that's required, and we've been hearing from states that they're going at it both ways. That some states are saying nope, it's up to the state, or it's up to the individual. Some states are saying they're going to require it, and so it's probably appropriate to have that discussion here today after we get through this.
And the other point would be, a consumer without children, is that consumer required to buy a pediatric dental plan?
If it's priced in the product that the insurer puts on the exchange based on, especially for a small group, based on a projected family size, they're gonna be paying for it. Right?
Yeah. So it's something we'll have to discuss as well.
All right, Mr. Haycock, you want to move ahead, please?
Thank you, Madam Chair. The table that some of you have in front of you and that we'll be going over, as John has mentioned, or excuse me, Mr. Hager's mentioned, that does have a column for standalone dental certification as well as standalone vision certification. So I will be going over both of those and providing opportunities for comment and discussion. The first is a general requirement, 156.200 subsection A. In order to participate with an exchange, an issuer must have in effect a certification issued by or recognized by the exchange that each plan it offers is a qualified health plan. Very basic, and yes, we believe that it should be included in standalone dental certification as well as standalone vision certification to keep it as a level playing field with medical qualified health plans. The next standard is issuer requirements, 156.200 subsection B1. Issuers must comply with QHP certification standards. Yes, we believe it's relevant for both. As well as the next one, issuers must be in compliance with all applicable exchange processes, all very basic administrative type of certification standards. Yes, we believe they should. The next one is where we finally have something that can be left out. Issuers must offer QHPs which cover all essential health benefits by default. This is only one essential health benefit for the dental side. And as Mr. Hager mentioned, the standalone vision will only cover adults, so therefore it does not need to offer all essential health benefits. So I can try to speed this along. I know there's a lot of these. The next one, QHP issuers must offer QHPs which comply with the cost-sharing limitations on deductibles and out-of-pocket maximums. And for here, yes, to an extent for the standalone dental certification, there are federal rules that came out of Federal Register that propose the plan must demonstrate the annual limitation on cost sharing is, in quotations, reasonable. For coverage of pediatric dental essential health benefits, that is about as specific as the rule has become to date. On the vision side, no out-of-pocket maximums should not apply to vision as there are no catastrophic events. The next standard, QHP issuers must offer QHPs which are offered at either the bronze, silver, platinum, or gold level of coverage. For dental, no, dental plans should be offered at low and high actuarial values, and no for the standalone vision certification.
Yeah, and we'll discuss this a little bit further on the next page, but the federal regulations that have indicated that they should be offered again at a low and high AV at 75 and 85%. Since that document came out, there was some information, I can't remember if it's from Delta Dental or from another organization, that said that 75 and 85% was unreasonable, and so we'll come back and look at that one as well. But I think there was some documentation that said it should be offered at 75% or 100% or something to that effect, and we'll discuss that one in more detail at the end as well. So three parking lot questions at this point.
Can you hear me out there?
Okay,
good. I'm pushing the. Oh wait, I think I got the technology right. Back on, and I don't know where vision crosses over into medical, but in terms of maybe this is another one of those questions you can address later. But in terms of out-of-pocket maximums for vision, somebody could have a serious vision problem. my world would be retinoblastoma, cancer of the eye, detached retina, where the treatment is very expensive. Now, I don't know where medical becomes vision, so maybe you're correct, but that would be my only question about that.
That would be medical, and I think the law specific when it calls it non-medical vision, right, which is traditionally a refraction and then the corrective lenses to cover that. Sometimes some of the plans also include some medical, somebody gets something in their eye and it's a lot easier to see the optometrist than the ophthalmologist. We actually do that as part of our plan, but I think that there's definitely a distinction for what we would call catastrophic medical versus the non-medical vision that's traditionally been offered.
Great, thank you.
Moving along, the next standard, QHP issuers must be licensed and in good standing to offer health insurance. Obviously, that is why we are here. Both dental and vision should apply this standard to their plans. On next page 4 at the top, QHP issuers must implement quality improvement strategies, disclose and report on health outcomes, implement enrollee satisfaction surveys as required under the ACA. Same for QHP medical. This should also apply to dental and vision certification, standalone dental and certification. QHP issuers must pay applicable user fees for the exchange, yes, proportional to the medical plan rates. There were adopted fees for calendar year 2014 where Mr. Hager discussed that the board had approved the fees for the standalone dental, and that, yes, for standalone vision proportional to the medical plan rates, which will be determined later. The next standard, QHP issuers must comply with risk adjustment, reinsurance, and risk corridors. No, we feel that doesn't apply to standalone dental or vision. Next standard and citation offering requirements must offer through the exchange at least one qualified health plan in the silver and gold metal tiers. And here's where Mr. Hager was discussing the actuarial values. Currently, the federal rules propose standalone dental plans meet a 75% actuarial value with a de minimis of plus or minus 2% to be considered low, and 85% actuarial value with a de minimis plus or minus 2% to be considered high. And there are no such standards or rulings on standalone vision products. The next certification, a qualified health plan issuer must offer a child-only plan at the same metal tier as any QHPs offered to cover an adult. Same for standalone dental, yes, but using low and high, although those numbers, like Mr. Hager said, may change. And yes, for standalone vision, but do not use metal tiers for standalone vision plans. To be completely honest, this should be only non-child, as was discussed at the beginning of this report for the standalone vision plan. So only to adults. Next, QHP issuers must adhere to any additional requirements established by the exchange or state agency as conditions. Very standard language. Yes, that should apply to both dental and vision plans. Then there's the non-discrimination standard and citation. QHP issuers must not discriminate with respect to its QHPs on the basis of race, color, national origin, disability, age, sex, gender, identity, or sexual orientation. And yes, that should be in both dental and vision certifications to maintain consistency and fairness. Then under the rate and benefit information, they must set rates for an entire benefit year or for the shop exchange for their specific plan year. Yes, so it maintains consistency with the medical qualified health plans for both the standalone dental and vision. QHP issuer must submit rate and benefit information to the exchange. Yes, for both. Justifications for rate increases must be submitted to the exchange prior to the implementation of the increase and must be posted on the QHP issuer's website. Yes, to the extent relevant, that's if they are going to make those actual increases or not for both dental and vision certification. As far as transparency and coverage, a QHP issuer must provide the following information. There's a lot of them: claims payment policies and practices, periodic financial disclosures, enrollment data, disenrollment data, data on denied claims, rating practices, out-of-network cost sharing and payment, and information on the applicable ACA consumer protections and market reforms. Yes, as appropriate, where those plans do cross over into these areas, they should be providing the following information to the exchange. Before I continue to kind of race through this, is there any questions or comments from anybody on what I've gone over so far?
I think.
Yes, Dr. Roberts here. I do have one question, and that's regarding the cost sharing and the requirement to be proportional or to be included in the medical cost sharing. I'd like some clarification. Most dental and standalone dental and vision plans purchased by employers have a benefit cap. For example, many standalone dental plans have a maximum benefit of $1,500 per calendar year. So, if the proportional cost sharing is to be shared between the medical and, let's say, a standalone dental or vision, is that also an implication that there is no cap on the dental and vision benefit?
My understand, this is John Hager for the record, my understanding is that will be changing in 2014. We will ask Mr. Mullins to come up here and speak to that as well when we get to the end, if you don't mind. So we have 4 items now. The last one is max benefit versus out-of-pocket maximum.
All right, then moving on to, we're now on page 6, transparency of cost-sharing information. Upon request, a QHP issuer must make available to an enrollee their cost-sharing with respect to furnishing of a specific service by a participating provider. Must be made at a minimum through the website and non-electronic means for individuals without access to the internet. Yes, we feel this is appropriate for both plans. Marketing and benefit design must comply with any applicable state laws and regulations regarding marketing, not discourage enrollment of individuals with significant health needs. Yes, for both plans. Network adequacy. QHP issuer must ensure that the provider network of each of its QHPs meets the following standards, that it includes the essential community providers, complies with any network adequacy standards established by the exchange, and is consistent with the network adequacies provisions of the Public Health Services Act. So yes, as appropriate and as essential community providers are available. Those for both of those plans. QHP issuer must make a provider directory for QHP available to the exchange, an online form, and to enroll these in hard copy upon request. Must identify providers that are not accepting new patients. Yes, we feel that's appropriate for both. Under essential community providers, a QHP issuer must have a sufficient number of essential community providers that serve predominantly low-income, medically underserved individuals in QHP's service areas. And that is yes, as those essential community providers and data are available. So we understand that may not be available immediately, but it must. We feel it must be part of the certification process for that specific standard. Primary care medical homes must provide. QHP issuer may provide coverage through a direct primary care medical home, so long as the QHP meets all applicable requirements. No, we don't feel this applies to dental or vision. Applications and notices, that the issuers must provide all applications and notices to enrollees in plain language and in a manner that provides for disabled and LEP access. Yes, for both, very standard in the industry. Rating variations. A QHP issuer must charge the same premium rate without regard to whether the plan is offered through an exchange, an agent, or direct, and it may vary by rating areas as set forth under the Public Health Services Act. Yes, to be consistent with the medical quality health plans, should be the same for both dental and standalone vision. Enrollment periods. An issuer must enroll a qualified individual during the initial and annual open enrollment periods and abide by the effective dates of the coverages established by the exchange. Yes, again, to be consistent with the medical QHPs. The enrollment process, that they must enroll a qualified individual only if the exchange notifies the issuer that the individual is a qualified individual and transmit enrollment information to the issuer. An individual approaches a QHP issuer directly for enrollment through the exchange. The issuer must direct the individual to the exchange and ensure that they receive an eligibility determination from the exchange. Yes and yes. Mr. Hager?
Going back to the enrollment periods, I'd like to add it only references initial and annual open enrollment periods. That should also include special enrollment periods. We copied this directly out of the regulation, but just like medical health plans, you should be allowed to newly participate in a vision or dental plan in the same manner that you can participate and enroll in a qualified health plan. So while we did not include it here because it wasn't copied, because this was copied out of the regulation, they should also be allowed to enroll or disenroll in the same manner as you would for a special enrollment for qualified health plans. So include special enrollment in there.
Next on page 8, enrollment data. QHP issuers must accept enrollment information in a HIPAA-compliant electronic format, acknowledge receipt of the enrollment information, and reconcile that data with the exchange on a monthly basis. Must supply a new enrollee with an enrollment package that meets exchange readability and accessibility requirements. Yes and yes for both plans. Premium payment. A QHP issuer must comply with the exchange procedures for payment of premium. Yes and yes again for both plans. Termination of coverage. They may only terminate coverage as permitted by the exchange. They must follow exchange rules for notification of termination and requirements regarding termination for non-payment of premium and availability of a payment grace period. Again, yes and yes. Accreditation. A QHP issuer must be accredited on the basis of local performance in the following categories: clinical quality measures, patient experience ratings, consumer access, utilization management, quality assurance, provider credentialing, complaints and appeals, network adequacy and access, patient information programs. Must maintain its accreditation for as long as the issuer offers QHPs. As far as both of these plans, we don't believe institutional accreditation exists for dental plans. I can't speak to that as 100% confidence. The research that we did, we couldn't find it, but if someone would like to correct us, now would be the time.
So we'll parking lot that. That's our 5th item.
Abortion services, I think that's self-explanatory. No, but neither dental or vision needs to provide those or deal with those. Standards for shop issuers. Shop issuers must, and there's a whole lengthy certification description, access payments, set rates by the plan year, enroll employees, accept new employees, and roll them in the exchange timelines. And all of those same standards for certification for shop issuers should apply also for those standalone dental and vision plans that will be offered on the shop exchange. Non-renewal and decertification of qualified health plans. If they elect to not seek recertification, the issuer must notify the exchange prior to the beginning of the recertification process, cover benefits for each enrollee through the end of the plan year, fulfill all data obligations from the last plan year, and provide written notice to enrollees, terminate enrollees in the QHP in compliance with the exchange's termination notification process. So for dental, that is yes. Dental plans must notify the exchange 6 months prior to termination of coverage, and that yes, vision must also notify the exchange. If a QHP is decertified, this is on page 10 now at the top. If a QHP is decertified by an exchange, the issuer must terminate coverage for enrollees only after the exchange has notified enrollees of the decertification, and the affected enrollees have an opportunity to elect new coverage. Yes, we believe this is important for both plans. QHP issuer must report to Health and Human Services information on its prescription drug program. No, this doesn't apply to the dental and vision. Exchanges may certify a health plan. This is the additional certification standards. May certify a health plan as a QHP if the issuer provides evidence that it complies with the minimum certification standards set forth above, and if the exchange determines that making the plan available is in the interest of the public. Yes and yes, similar to the medical health plans. As far as service areas of the quality health plan, the service areas of a QHP must cover a geographical area that is at least the entire geographical area of a county or a group of counties as defined by the exchange, unless the exchange determines that a smaller service area is necessary, non-discriminatory, and in the interests of the public. The service area must be established without regard to racial, ethnic, language, or health status factors or any other factors to include utilizing high cost or medically underserved populations. Yes, it should apply to both to ensure fairness for the citizens who will elect to utilize these plans. And finally, the last citation only applies to the standalone dental because it is only a standalone dental plan certification that they must meet the definition of a limited scope dental plan under the code in the Public Health Services Act, cover at least the pediatric essential benefits without any annual or lifetime dollar limit on those specific benefits. So I believe that answers that one question about annual limits on your dental plan. And must meet qualified health plan certification standards if the requirements can be met by a dental-only plan. Yes, of course, for dental. No, it's not applicable to the standalone vision plans. The recommendations is that we validate all of these, alter if necessary, and improve the general requirements provided in this report for standalone dental and vision plans so we can move forward with that certification process pending the decision on our BDR and the other decisions by the board.
Madam Chair, if you don't mind, I'd like to offer the opportunity for the Division of Insurance to come up here if they've got any additional comments that we haven't already covered. It could be that in our discussions I already took care of it, but Cliff King is approaching from the division.
Ron Klein, could I ask a quick question, please?
Certainly, Dr. Klein.
Sorry, and this may sort of along the same lines as before. Under prescription drugs for a vision plan, I'm sure the health plan directors can help me with this. If somebody has glaucoma and they need medicines, is that covered by medical or is that covered by vision? Okay, great. Same question. Thank you.
What was the answer?
Medical.
Medical, okay.
Medical.
Thank you. Cliff King, Division of Insurance. At CSIO's own admission, there's not been a lot of attention given yet to the standalone dental or vision. And we're really in a fog, if you will, with where we are with the standalone products.
Mr. King, just for a minute. For those of you on the phone, someone does not have their phone muted and we're getting a lot of background noise. If I might remind you to mute your phone so we're not picking it up in the hearing here. Thank you.
Maybe we'll find something juicy, you know. Why don't we tell everybody else who wants to call back in to call back in and we hang up?
It won't work.
It doesn't
It'll
work.
still be on.
They'll still be on the line. We tried that once before.
Okay.
Again, if I might remind those people on the phone to please mute your phone. We're hearing background conversations.
You know how this happens? I don't know how it happens. I'm confused.
I'm really sorry for you, but just hang up the phone.
Go ahead.
Okay, so-
Let's see if we can.
At any rate, it's early on in this. We're still getting directions from CSIO on how we're going to proceed. There was a position paper authored by the National Association of Dental Plans and Delta Dental that talked about the difficulty in identifying how you achieve metal tiers with dental products, particularly with regard to the fact that most of the premium goes to prevention as opposed to treatment. Very little, you know, you normally see like $1,000, $1,500 limit for your treatment in a dental plan, whereas you got almost unlimited for the preventive services side, like 4 clinics a year or something. So at any rate, at the division, we're kind of we're not prepared to start qualifying dental plans at this time because we just don't have enough guidance from the CSIO. That's basically where we sit.
Thank you. I appreciate that. All right, so we have, what, five questions here that we want to address?
And an additional question that I've got.
Okay,
Could we bring Mr. Mullins up to the table?
certainly.
Again, for the record, John Hager. Mr. Mullins, for the December board meeting, Delta Dental provided a letter to us indicating that it intended to offer products in the exchange. Obviously, that helps the qualified health plans know that they can offer products within the exchange without the dental benefit. We appreciate that letter. It did not clarify whether it would be on the individual side or on the shop side or both. Could you please clarify that?
Yeah, we would offer in both the individual exchange and shop exchange.
Excellent. We appreciate having that on the record just so that everybody's clear. It's on both sides. The next question, of course, we have to ask is the outside versus inside and how that works. What is your understanding of the way the regulation of the law reads, or is it law or regulation that requires it be offered, does it require it be offered outside the exchange with the medical health plan?
Yeah, so the understanding here is that the provision that I mentioned earlier in the Affordable Care Act that provides the waiver only provides that waiver inside the exchange. The language is less than clear, and in fact, the Senate committee mark of the bill indicated it was supposed to apply both inside and outside, but that did not get into the law the way it probably should have. So Senator Stabenow continues to try to work with HHS to push that issue. But there has not been any clarification issued by HHS. They feel they don't have the authority to overrule what the Affordable Care Act says. So today, a qualified health plan cannot offer the essential health benefit package without the pediatric dental outside the exchange. There are some states that have taken a look at this, and they don't really like this positioning, because I agree that there is a provision also in the rules, I believe, that say if you offer the same plan that you offer inside an exchange, outside an exchange, it must be priced the same. But that's if you offer the same product. So a qualified health plan without a pediatric dental component inside an exchange, therefore would not offer that product outside the exchange. And I think that can be allowed. However, outside the exchange, all 10 essential health benefits have to be covered by a qualified health plan. So some states are looking at this and saying, well, perhaps the qualified health plan can offer the pediatric dental as a rider. So they are offering all the benefits, and that conforms with the law, but the purchaser could, as riders work, to my understanding, could say, I don't want the dental rider because I'm going to fulfill it with a standalone product instead. However, we are also anxiously awaiting the final essential health benefit rule, which we hope, again, will clarify this issue, that HHS will issue rulemaking that will allow this waiver outside of the exchange as well.
And then that leads us to the third question, the requirement to purchase pediatric dental coverage. So then is it your position that while it's required to be offered by the qualified health plan or by the standalone dental plan, it is not required to be purchased for the child?
Yes, our understanding is that it's a required purchase for children, but it's because it is limited to pediatric. Now, HHS has defined pediatric as age 19. I think they've left it to each state to either choose that age in definition of pediatric, something that this exchange will have to do as well, or a state can go higher than that age. But because the product is limited to that definition of age, the question that is outstanding and has not been clarified by rule is, well, who is required to purchase it? So states are taking different positions. Some states are saying everyone has to purchase it. Washington, for instance. California seems to be heading in that direction. I think the logic there is that it's like maternity coverage in a medical plan doesn't benefit a male. But it spreads the cost, as insurance is one of the fundamental principles of insurance, is spread the risk and spread the cost amongst the largest amount of the population, drives the cost down. There's validity to that argument. There's also validity that says this is the Affordable Care Act, and the purchase is supposed to be affordable. So why are you forcing adults who don't have children to buy a pediatric dental and vision product that they can't use? And then they have to go out and go shopping for an adult dental and vision product that they can use. So they are paying for duplicate benefits, one they can't use. So it doesn't seem to make a lot of sense, and many states, therefore, are not requiring the purchase by adults. I will say that that is something we favor, because what it does is it incentivizes the qualified health plan to separately offer the medical only versus their pediatric dental or vision. Because then the adults have the choice of saying, I don't need this other product. The other problem, I would say, for a standalone dental plan is in states where they are saying it's a required purchase for everyone, a qualified health plan can therefore allay the cost of a pediatric dental and vision product amongst the entire population. Now that does, of course, drive the cost down, but a standalone dental or vision plan sits out there, and the only people who are going to look for those products are people who need them. There wouldn't be any purpose for an adult to look for a standalone pediatric policy. So they will likely buy it in conjunction with a qualified health plan if they're forced to. It may cost less, but it makes the standalone dental plan out there, who will have virtually 100% utilization of the benefit, a much higher priced product. And so therefore, any type of competition that you might have had there is kind of obfuscated by requiring adults to purchase a product that they can't use.
So one thing I'd like to add to that, while he discussed whether or not the age limit for pediatric dental should be at 19, that is an essential health benefit issue, which is market-wide, which would be up to the Division of Insurance to decide. This committee could provide a recommendation, but it's ultimately the commissioner's responsibility to, or the Division of Insurance's area of expertise, if you will. Because it's market-wide, we should not be requiring something that's different inside the exchange versus outside the exchange that could create some disparities, also create difficulties for the health plans that will have to will have to price those plans the same inside and outside the exchange. And again, we're trying for consistency here. So
I looked up Nevada Checkup yesterday. It's 18 years, 11 months.
And so the 19-year-old threshold, is that the 19th birthday?
It is. So at the
Okay, so it's
19th
basically
birthday,
the same.
it drops. So that would conform to the CHIP benefit, and,
Right.
and that's what we've stated in most states that have chosen a CHIP benefit is if you want that kind of similarity and continuity, that is why I think HHS chose 19. But it did allow a state to go higher. Oregon went to 21, for instance.
Can you provide more, if there aren't any questions about that, I've got the next item is on the actuarial values. Are there any questions so far?
I have a question. So, Steve Woodley for the record. Mr. Mullen, when you were talking about the standalone dental, and maybe this is an important point that I missed, you were speaking in terms of just a subset product for pediatric dental to satisfy the requirement. Is there anything in the law that would preclude the standalone dental product to offer benefits across the spectrum? So it would include pediatric dental, but all the way up to adult, as a regular dental plan. And then adults would have access to it. It would satisfy the requirements to have pediatric dental, and then you would increase your market share in terms of the uptake. So maybe I'm thinking all along that the standalone dental was going to include the full spectrum of adults through children, but maybe you were thinking of just to satisfy the requirement of the waiver, which is just a pediatric dental benefit of some, plan design which is different and unique to them, that population.
I think states have the absolute flexibility to offer supplemental coverage. I think the rules made that clear, and most states are. There are maybe a couple of states that say we don't have the time, or our web portal doesn't, the IT build is not going to be there to include it, but we'll do it in the future. I don't know where Nevada sits on that point. We hope to offer supplemental as well. What we fear is that adults will go to the exchange in order to be subsidized and purchase the pediatric and then drop their own coverage. And that's not something that we want to see. So we would like to be able to offer the pediatric essential benefit as a standalone dental product. And it has to be offered by itself because there's so many of these certification rules and requirements that only attach to the pediatric. So for instance, the annual limits that Damon mentioned do not apply to supplemental adult. There can be annual limits on those products. So you've got a difference in product. So there would be the pediatric component, and then what we would do is put the pediatric component in with a buy-up kind of wrap coverage to include family, adult, even adult by themselves without any child coverage. So we would certainly offer a full gamut of the product to accommodate whatever the consumer's needs were.
Something to be clear on, the advanced premium tax credit and cost sharing reduction, well, cost sharing reductions will only really apply to the medical plans, but the advanced premium tax credit will apply to the combined premium for a medical health plan and the standalone vision plan for children. So, for instance, if the second lowest cost plan, when you add up the medical plan with the standalone vision plan, or if it's a combined plan, is a certain price, the APTC will apply to the calculation.
You mean vision or dental now?
I'm sorry, dental. Did I say
Okay.
vision? I meant
Yeah.
dental. It will apply to the entire premium, or it will be calculated based on the entire premium. For adults, the adult dental is not part of the essential health benefits. Therefore, it would have to be pulled out for the premium, and the adult would have to pay the full cost of that piece. The APTC would not apply for that piece of it. Now, because of the way the APTC is calculated, it will appear that the full cost of coverage for dental, regardless whether you're a child or adult, will appear to have to be paid for by the individual, but the APTC is in fact increased for the pediatric dental. So that's another reason why it would have to be broken out. So when we go forward, that's those two pieces, both the differences in the requirements for children, and then the APTC itself. When we put this together, we had not contemplated having adult dental plans that were, other than the few things that are very definitely for children. We had not contemplated any differences between the two plans, but that might be something that we need to consider. So we, like for instance, this last one where without the annual or lifetime dollar limit, we had lumped it together as a standalone dental product, whether it was pediatric or adult. I don't know if it makes sense to keep those the same or to break them out, as Mr. Mullins had indicated.
So I guess I would ask the question whether or not if one plan was created as dental, whether or not it's reasonable to have different benefits for children versus adults, or is that discriminatory? So basically, if you have to put together the equivalent, since you can't have the maximums, and I'm waiting to figure out how you're going to do that. Where you offered the adults at where they are today, preventive okay, but then 50% of the cost of the network up to $1,000 or $1,500, that doesn't pay for anything. I mean, I get phone calls all the time from our senior people yelling at me about the standalone dental plan that we sell, but that's the pricing for the benefit that is this industry standard. Is that something the DOI would entertain? Differential benefits by age?
Too early to say.
So for the record, Mr. King said it's too early to say. I will say that getting into some of the weeds on this, I had hoped that this would be the last meeting of this committee, but it appears that we're going to have more discussion to follow up on this. I think we're going to have to refine this report, perhaps break out adult from children for dental, and hopefully get some better comments from SOSIO. So hopefully we can have this discussion at the end of February or early March. We are hesitant to do it too much later than that because we want to make sure the plans have a time to provide their plans to the DOI for certification, but we do need to make sure we get some clarification on some of these things. Again, SOSIO has not offered up a ton of information on these, and so we need to try to push them to get us more information on these items. Otherwise, it will end up that we won't have standalone dental products because we can't make it work, and I don't think we want that. So we'll try and push them to get more information. So that said, we still have some more items to cover unless there are any other questions. I just want to make sure that we understand that we'll probably have to revisit this again.
I think that there are some things on this table that we all agree we don't need to look at again.
Mm-hmm.
And would it be possible for staff to separate those out so that we just focus on the areas that we need to focus on?
Sure.
And maybe if we might just go back over pages 3 through 11 and identify those that we think we need to look at again, and then maybe move the other items so that they're off the table for us now. I was going to say on page 3, I think it's next to the last, where the high-low on the dental plans was an area of question, and everything else on that page was okay.
Yep.
And then on page,
Madam Chair, this is Wayne Finch. I'd like to offer an additional clarification on that page.
yes,
The second item regarding user fees for the exchange, I'd like to ask the committee to reference that in conjunction with the third item on page 7 regarding the issuer must charge the same premium rate without regard to whether the plan is offered on the exchange or off the exchange. How would the inclusion of that user issuer fee, if the person purchases on the exchange, would be subject to the fee? However, if a person offers or buys that same product off the exchange, would not be subject to that fee. How do you then deal with the issue of the issuer fee creating a difference in the premium?
Okay, I think Mr. Hager can answer your question on that, but which item is it on page 3? Which,
Page 3 is the second item, 156.200B6.
That's page 4.
Page 4.
That's page.
oh, that, you're on the next
Page
page.
4, excuse me, page 4.
Okay, let me just clarify, there's only one item on page 3 that we need to, and that's the dental plan should be offered at low or high actuarial values. Is that correct? Hearing no objections, I
Well,
think.
this one too, you wanna endorse this one that says that all essential health benefits don't have to be covered. Only the pediatric dental. So you're saying everything's fine on this page?
Except for this.
Okay, alright, okay.
Okay,
I could.
okay, so then going on to page 4.
Right, that's where my comment was.
Okay,
So just to clarify, we're going through and identifying the ones that we're going to have more discussion on, and those that are not identified, we will go ahead and try to make a motion, perhaps to approve the staff report as is for those that are not identified. Does that make sense?
correct.
So on page 3, it's the second to last item. It's 156.200B3, 156.20. So it's QHP issuers must offer QHPs that are at the bronze, silver, platinum level. That one we're pulling out as for working discussion.
John, just a point, what about the one right above it though, which is the out-of-pocket maximum?
Yeah, and I believe that one goes with the very last
Now he's
one.
taking a bath.
So I think we should pull that one as well.
Okay.
So on page 3, it's the 5th and 6th items.
And so just as, to clarify for myself, we're not suggesting that anything not chosen is equally applicable to an adult dental plan. We're just saying they don't need further discussion.
We will break these out. If you're on the phone, can you please mute your phone? We're going to break these out. We will bring this entire report back to the committee, and so even if we make a recommendation on the ones that we don't pull out, we will break them out again and clarify which ones the committee has felt comfortable with, and we can do that once again at the next committee.
I'm sorry. I'm not ready to eliminate this one because you have to redefine what is reasonable cost sharing. If you're not going in to say it's going to be the HSA limit 6350 or whatever it is, somehow there'll have to be some way to come up with what is reasonable cost sharing on behalf of this. So yeah, you can eliminate, I would say you could eliminate the aggregate out-of-pocket cost sharing, but you also have to look at since this is part of the EHB, what does that mean for a plan who has a standalone dental plan that they buy, and we decide that reasonable is $400, right? That.
Excuse me, just for a minute. If you're on the phone and you're coughing right now, could you please mute your phone?
That was me, Madam Chair, and I don't know how to mute this microphone, unfortunately.
Okay, I'm sorry. It sounds like we've got somebody in the background that's really. If you're on the telephone, can you mute your phones, please?
Sounds like they're outside.
So
It's like the wind.
For those of you who are on the phone, I think if you hit star 6, sometimes star 5, but star 6 usually will mute your line.
you can't do it without ending the conference, right? So what I'm saying is, since the out-of-pocket was supposed to apply to both, to all the essential health benefits, and I'm playing devil's advocate here, right? And there's a determination about what a reasonable cost sharing is on the dental plan. Does that mean that every medical plan who is not that is counting on people to take the standalone dental plan now has a reduced amount of cost sharing that they can put in their medical plan? I mean,
All right, so my understanding, what you're saying is medical QHPs are required to follow the 60, 70, 80, and 90% AV, and there is a separate cost sharing for dental, and how does that affect that, whatever we determine for dental, does that affect the metal tiers of the
no,
medical
what I'm
plans?
saying is there's a maximum deductible and a maximum out of pocket that we have to meet for those plans. So if it's a determination, and since the pediatric dental benefit is aggregated in that expectation, what happens when you determine that there's a reasonable cost share for dental? Does that maximum cost share have to be subtracted from the standalone, from the medical plans, so that the members' maximum out of pocket meets the intent of the law?
Okay.
That's what I'm asking.
Mr. Mullins, do you have an answer for that?
I can't really speak for the medical plans. My understanding certainly is that standalone dental, in the latest rulemaking for essential health benefits that came out November 21st, said that standalone dental should have a separate out-of-pocket maximum, and it must be reasonable. We had Milliman do an analysis for pediatric dental, and they came out at a $500 out-of-pocket max would basically suggest that 4% of children will hit that out-of-pocket max, and therefore there is justification it could be at $500. There is also justification, and we support the $1,000 out-of-pocket max. That, in their analysis, suggests that 2% of pediatric children would hit that out-of-pocket max. The balance that an exchange has to keep in mind is the lower you bring that out-of-pocket max, the higher the AV, and the more cost sharing you're going to require for preventive and diagnostic benefits. So it's a question of, do you want to help the 4% at the expense of the 96% and make them pay more cost sharing for dental visits? Or do you want to have higher cost sharing for 98% and at $1,000 help the 2%? It's about the catastrophic nature of what out-of-pocket maximums are supposed to help the individuals with. So right now we support 1,000. We've suggested that HHS rule that, like they did with pediatric age being 19, suggests that that's what they are going to follow for the federally facilitated exchanges, and let states either conform to that amount or choose a different amount. California recently, after we went through this negotiation with them, settled on 1,000.
So just to be clear, your understanding is that the standalone dental product can have a separate out-of-pocket maximum from the medical plan, but we haven't heard anything on how that works for the one that has dental embedded, which would, in the result would be a lower out-of-pocket maximum for the embedded plans, which would mean a higher premium for the embedded plans because they'd have to incur that extra cost.
Unless the embedded plan said, here's your medical and here's your dental. Separately. So you have what's mandated by law here, and since HHS has said this is a reasonable number, or the state DOI says this is a reasonable number, then you would have both accumulate according to the services that were used. I mean, I think the health plans need to understand that going forward, because we're working with our actuaries now on what we should do. Same thing with vision. Although I'm thrilled that you guys did a BDR, we're going to have to figure out a response to that in order to facilitate filings and plan document work. Otherwise, we'll be amending everything until June, and you won't get what you need by July.
Well, the the requirement, the request for the BDR,
Yeah,
um,
and I'm not being dismissive, I mean, I think,
Sure.
yeah,
but the request for the BDR is to be able to offer a standalone vision product.
right.
So your concern is taking out adult vision?
No, my concern is it's a similar thing when we're going in there and we're trying to price an essential benefit plan, right? So we're doing that plan because we don't have the authority today to say the vision plan is gonna be standalone. We have to make the assumption that some portion of that has to be included in the overall rating of the product. That's all I'm saying.
Right, so even if the state legislature authorizes the exchange to offer a standalone vision product, the carriers will still be required to offer pediatric vision within their plan. So that will never be separated.
Right,
So we're only talking about adult vision.
right.
And
Right.
and so your concern is whether or not you separate out the adult
No,
vision
I'm just
piece.
saying that regardless of whether or not we get whether or not pediatric vision's allowed to be offered on its own, we may not have the information in time, and it may be put in our rates anyway.
Right, and pediatric vision will not be offered on its own.
Okay,
That will not happen because the federal law won't allow that.
okay.
I would add that I think I've talked to some medical plans, and they feel like this is another incentive to separate out their dental pediatric because they would rather have the separate out-of-pocket max. They'd really rather have a separate deductible. If the deductible is $2,000 in a embedded qualified health plan, if you're using your dental benefits before you use any medical, that's an illusory benefit. You will be paying for almost everything at 100% until you hit that $2,000 deductible. So the idea is that it's much more beneficial to the consumer for the qualified health plan to break that out because they can take advantage of the separate deductible, separate out-of-pocket maximum. They don't have to coordinate in their claims processing because they're different. How is the medical claim and the dental claim combining to reach this out-of-pocket maximum, which is a systems issue for a lot of medical plans. So that's all I can say about the medical.
Right, so it's those two.
Yeah, so the end result of that conversation was items 5 and 6 on page 3. We need to either discuss more, I think we've pretty much discussed them today, but provide more detail and hopefully get more guidance. We'll discuss with the DOI and see where we can get on that. And then on page 4,
It's the fourth one,
the fourth item, and
offering requirements.
and there was a question about item number 2. Did we? I don't think I answered that question yet, did I?
Right, this is Wayne Finch again. That was item number 2, 156.200B6, the second item on page 4.
Right. So.
And I was looking for clarification of that in conjunction with on page 7, Mr. Hager, the third item called rating variations.
Yes. So.
Getting a QH. Okay. Go
Yeah,
ahead.
the same thing works with the medical qualified health plans. Excuse me. So, basically what happens is we're going to charge a fee for the plans for the enrollment within the exchange. That's going to be a cost that the carrier is going to have to add into their products. Again, as we said before, we don't want carriers to lose money because they'll go away and then we'll have less competition and costs will go up. And there are other mechanisms to cap the amount that they can actually make. So the example is, let's pretend, this is illustrative only, we are not charging $10 per member per month, but this makes it easy math. So for illustration only, let's pretend we're charging a medical qualified health plan $10 per member per month. And we pretend that 75% of their population is estimated to be on the exchange, on a medical QHP on the exchange, and 25% is going to be on that same QHP off the exchange. We're only going to charge for that 75% on the exchange. They're going to have to distribute that on their price throughout because it has to be the same both on and off the exchange. So they will likely have to add in a charge that's $7.50 PM to make sure that they can cover their costs and make sure their costs are the same both on and off the exchange. So they will charge the same rate both on and off the exchange, and they will give us their fees based on enrollment within the exchange. The same thing will happen with the dental and the vision plans, but the fee that we're going to charge is going to be proportionally less. So at the January board meeting, not only did the board adopt regulations to set the fees for qualified health plans without dental, qualified health plans with dental, and for dental plans, standalone dental plans, but they also voted to set the rates themselves. And the way that they were set is that the dental plan fee was proportionately smaller to the medical qualified health plan, and that was based on current premiums in the current market today. Or I think it was actually 2011 is the data that we have. So going forward for the second item, our proposal is to look at the fees, the premiums that were charged for vision plans in 2011, and make that fee that's charged to vision plans in 2014 a ratio of the vision premiums compared to the medical qualified health premiums. If you look on our
dental.
It'll be based on the medical. Because vision premiums are usually less than dental premiums.
Okay.
It's likely that the vision, as long as the vision premiums in 2012 were less than the dental premiums, the fees will be less in 2014 than the dental fees. If you look on our website at the January board meeting, you can look at how we calculated the QHP and dental fees. We will calculate them in the same manner using the vision premiums. Again, that's at the top of I believe it's the second link on the January board meeting agenda. If you look at there, and that will pretty much explain how that's going to be calculated. Does that make sense?
Yes,
thank you, Mr. Hager.
Oh, I'm sorry. And if I could add, Jim Mullen again, the exchange is performing a very important and big administrative function inside the exchange in aggregating premium that will absolve a health plan, medical and dental and vision, outside the exchange from having to do that. So that's an administrative cost that usually gets borne out in fees, a premium. Outside exchange products, the health plan would continue to do the premium collection and et cetera. So that, I'm not sure that equally balances anything, so I agree with your comments about how it would be allayed across all of the product.
So, Mr. Finch, does that answer the question for you? And are you all right with that second item on page 4?
Yes, that answers the technical aspect of the question, yes.
All right, so the only item then that we want to hold for further discussion is the fourth item under offering requirements on page 4. I don't have anything circled on page 5. Nor on page 6. On page 7, we edited the fourth one down to add special enrollment periods. And was there a question about rating variations that we wanted to hold for further discussion, or are we all right with that?
I think we're good there.
Okay,
So special enrollment and qualifying events, right? That's where you're going?
under enrollment period.
Yes.
On enrollment period, qualifying events that let people go into the exchange off open enrollment, that's what you're saying.
Yes, the same. So the way that we are setting up the exchange to get a standalone vision or standalone dental product on the exchange, you are first going to be required to purchase a medical plan. You're not going to be able to just purchase a standalone vision or dental plan on the exchange. The purpose of the exchange is to provide medical coverage. That's the main purpose. Part of the reason why we are only getting to dental and vision today is because we've been focusing on medical plans, to Delta Dental's dismay, I'm sure, but we're getting there. So you go to the exchange, you purchase a medical qualified health plan, and then you have the options of selecting the other plans.
All right, so that means that if somebody comes in and they bought standalone dental and they bought medical, and we get a notice they want to term their medical, that their dental is automatically going to be terminated as well. That those processes, and vice versa, would happen.
Yes, we will have to be very clear on our termination notices that is linked together. Now, they could term a medical qualified health. If there's a special enrollment, they're already enrolled in a qualified health plan. They have a special enrollment that would allow them to change qualified health plans. They could continue with the same dental and vision. So they might get a termination for the qualified health plan because they're enrolling in a new one
Right.
and still have coverage. But if they terminate from exchange coverage,
Because they have group coverage, so suppose they have group coverage.
yeah, group
And-
or individual, either way,
Yeah, I mean,
yeah.
large group, so they don't have, they change jobs, now they have large group. They're not in the exchange, they're not subsidized anymore. When they send that notice in, you wipe everything they have away.
Yes, and we'll have to be very clear on that.
If I could, I'm not sure that, that could be, I'm trying to think that the exchange is a marketplace to offer coverage, it's not there to require purchase. The IRS is supposed to enforce the individual mandate. This is what we've heard from HHS, so I would suggest maybe having a conversation with them. I could foresee someone having medical coverage through their employer that meets minimum essential coverage, and that employer doesn't offer dental. And that employer has a child, and they don't make, or they make an amount of income that would qualify them for a subsidy for that child, and therefore why can't they go to the exchange to buy a standalone pediatric dental product? They have coverage outside the exchange in either a large group setting, small group setting, and they
That's not the
don't
intent of the
have
law, right?
dental coverage.
And I don't know what the intent of the law is in regards to that. Our read of the law is that if you offer a qualified health plan on the exchange, you have to offer it off the exchange. I don't know how applicable that is to the standalone dental product. But theoretically, if that follows, then if you can't get it on the exchange, you could get it off the exchange for the same price. If we're saying here that the, excuse me, under, I think it was page 7 on item 3, if a QHP issuer must charge the same premium rate without regard to whether the plan is offered through an exchange, an agent, or direct, so basically that it has to be offered at the same rate on or off the exchange, you could theoretically get that plan off the exchange.
I'm talking about state of Nevada.
Right.
So suppose state of Nevada doesn't offer dental anymore, all right? And somebody comes to work for the state and picks home.
Excuse me, Dr. Ash Jackson, could you please pull your microphone
Okay,
closer to you? We can't hear you very well down here in Las Vegas.
I'm sorry. I'm
Thank
saying,
you.
so suppose somebody goes to work for the state of Nevada and they suddenly have state of Nevada large group insurance. But the state doesn't offer the essential, because it's a large group, doesn't have to offer every essential health benefit. It's only if it's offered that they need to meet the intention of the law, correct? So they choose not to offer pediatric dental for the sake of argument. Does that mean that that person can go back into the exchange, can stay in the exchange on the dental side? Mr. Mullen's saying, yeah, they should be able to come into the exchange on the dental side. I'm not sure where the insurers are gonna be on that, especially if there's a separate adult and I don't know if that means that now every insurer has to split their pediatric and adult products because they're offering something that's like pediatric benefits if somebody happens to have a child. I think we need to talk to the Department of Insurance about that, what that means for us going forward. And whether or not you're gonna let people buy pediatric dental in the exchange without regard to what their coverages are.
So we're still at the point where we can make some changes to our system if we need to. We're getting close to the deadlines where we can't make them anymore. But let me make sure I understand, Mr. Mullins, your point of view is that you would like to be able to have people on the exchange purchase only standalone dental if that's what they want, because they could have other coverage elsewhere.
I mean, we would just say that that it's not whether we would like it, it's whether the consumer would be open to being able to shop in the exchange for all the products. I mean, if you barred it, then you would just force them to go outside the exchange, where then you would not be allowing them to take advantage of a tax subsidy.
Madam Chair, if a consumer is in right now a waived plan, a waivered plan, but it doesn't cover pediatric Dental, does that mean that they would be able to go on the exchange just for that product? I mean, I think that's a policy question that we may want to have explored. That changes the dynamic significantly in terms of future group decisions about coverage.
Right.
And Dr. Jackson, can I ask, are you, excuse me, are you concerned from the plan's perspective that, or are you indicating that maybe we should offer it by itself, or that there would be concern from carriers that we shouldn't?
I'm asking the question. I mean, it's less of an issue for us because we don't offer dental and take the risk on dental except for our senior product. But does that mean that when one of the vendors comes back to us who supplies dental to us, if they come back to us and they say, well, I'm not sure what I should quote you, should I quote you adult only? Should I quote you the aggregate, what does that aggregate plan look like now? Because technically I'm offering pediatric if they have a child. And if it's an essential benefit, what does that mean in terms of no out-of-pocket max, all that other stuff for the different age groups? I'm asking the question because I think it's confusing when you're looking at large group. It's not as confusing when you're looking at small group, but when you're looking at large group, it could have significant implications on cost and on what's offered. And so, you know, I'm just raising the question because I don't know what the right answer is.
John, I have a solution.
This is Ron Klein. Is there any problem with just offering the whole spectrum of plans, family plans, pediatric plans, adult plans on the exchange? Is that not possible? I mean, it seems like maybe I'm missing something in the conversation, but it seems like we're trying to make an either or kind of decision when it really should be an and decision, and we could offer them all.
So we are certainly offering them all, and I need to go back and talk with Xerox and make sure that I think we can offer them separately. I want to make sure, I want to see how far down the path we are in creating this to make sure that whether or not it has to be pegged to the medical plan. So I'll come back with information at the next meeting.
And John, the only other question I had, just in terms of detail, and this is only because it's the federal government and they like to harp on words. I think the way the exchange rules read is that you can't buy a product on the exchange if you can purchase health insurance through your affordable health insurance through your employer. So to cite the example somebody else did before, that you had a plan through your employer that didn't offer pediatric coverage, would you still be allowed to go to the exchange and purchase pediatric coverage, or would that be disallowed because according to the federal government rules you can't go on the exchange if you have affordable health care offered through your employer?
So it isn't that you can't get coverage on the exchange, but that rule is tied to the advanced premium tax credit. So if your employer offers affordable minimum essential coverage, you can still go to the exchange to get coverage and opt out of your employer's coverage, but you would not be eligible for the advanced premium tax credit.
So then I guess to take your point a little further, and it becomes a smaller issue then, is that, again, it's just sort of one of those things to clarify with CSIO. If you have affordable health insurance through your employer and you qualify for an advanced premium tax credit, and you went to the exchange to get dental insurance, pediatric dental insurance, you wouldn't be able to, even though your employer didn't offer that benefit, you wouldn't get the subsidy. I'm wondering if it's a very, very small point, but I'm wondering if that's correct.
I believe that you only get the subsidy if you enroll in a qualified health plan through the exchange. So if you enroll in just a dental plan, you would not be eligible for the subsidy.
So the standalone dental and vision plans don't have subsidies attached to them?
They do if you enroll in a qualified health plan. So this is part of the problem why it's difficult to, and we can make it work. But The only way that you get the tax credit is if you enroll in a qualified health plan through the exchange. If you enroll in, the amount of the advanced premium tax credit is based on the premium for the qualified health plan, and if that plan doesn't have dental, then it would be based on the dental plan that we choose as well. And so you would get an APTC that's equal to whatever the calculation is for the full cost of coverage for all your essential health benefits. But if you don't enroll in the qualified health plan, you would not get a subsidy for that, for purchasing the standalone dental product by itself. So I think that was part of the reason why we were considering saying you had to enroll in a qualified health plan to do these other things. We can make it so that you can purchase a dental or vision plan separately, but you would not be eligible for an APTC for any supplemental products unless you were enrolled in a qualified health plan through the exchange.
John, this is Steve Whitley for the record. So my idea, or at least my thought for a path forward, back to the original question, is if we follow that the idea of the waiver permitting a standalone pediatric dental plan on the exchange is to complete fulfillment of a qualified health plan's 10 requirements, then to me, if the option from the carrier is to not embed it and allow it on the exchange and Delta Dental is providing that service, if you give notice to the exchange that you're terminating your qualified health plan, then that waivered pediatric dental plan goes away the same time. Conversely, if I am covered through an employer plan that has affordable coverage, meets minimum value, but does not offer dental, then I could go to the exchange like any other marketplace and I could buy the full dental plan, which would include coverage for any of my children as far as myself and as an adult. So to your point, I think if the only purpose for the standalone dental as a separate product on the exchange is fulfillment of the 10 essential health benefits required, if you terminate the QHP, the pediatric dental standalone goes away at the same time. But the option is available for a full spectrum dental plan on the individual exchange if my employer provides affordable and minimum value coverage, but I don't have dental, then I can go there just like any other marketplace and buy it. That's the way I would view it.
But do you get the tax credit?
It's
No.
as part of the QHP only.
No, yeah, the only way you get the tax credit.
No, because you have affordable coverage.
Right, well, because you haven't enrolled in a QHP, even if you
Right.
don't have affordable coverage, the minimum essential coverage off the exchange, if you have no coverage at all you want is dental, you would not get the tax credit. You have to enroll in a QHP to get the tax credit, and that is very clear by the IRS rules.
Okay.
So that was my point.
All right, so let's go back to which items we're going to.
I was just going to say, I agree, John, with your analysis of the advanced premium tax credit may be contingent upon choosing a QHP and then devolving down to the pediatric dental if it's chosen. I just think I don't have any answers, but I think conversation with HHS and those officials might be beneficial because there's a whole gamut of life circumstances. I mean, an employer can offer dental coverage and make it applicable only to the employee or only to the employee and spouse. There are very many life circumstances that I think an exchange needs to consider that individuals, families, so they wouldn't need a family policy then. All they would need is to cover their children. So I'm not saying that's a large part of the population, I'm just saying it's difficult to try to figure out the various circumstances that people find themselves in and why they may come to an exchange as a marketplace to purchase something. But if the tax credit isn't available, I would say for pediatric dental, the advanced premium tax credit is going to apply very, very rarely under the way the rule is established. I won't go into the details, but it really, there won't be anything, it all goes to the medical, and only if there's something left over will it go to the pediatric dental. And there's never going to be very much left over. It would have to be a bronze level, low bronze level plan, basically.
All right, again, let's go back to page 7, and I believe it's the third item that we want to pull for further discussion under rating variations. Under enrollment periods, I think we've agreed to the amendment in the language. Going to page 8.
On page 8, I would just make the point that credentialing is not the only thing that should be considered, because there are predeterminations and utilization management decisions made in dental plans, much as they are in medical plans. So if there's no, quote, accreditation beyond credentialing today, I would recommend that there be some sort of a standard set that the Department Division of Insurance could administer around this quality intent on the last the fourth one in the grid.
Okay, so we want to pull that for further discussion then?
Yeah, I'd like to ask a question.
Okay.
Mr. Mullins, we couldn't find any data online that says that that dental plans should or are required to be accredited. I believe we found one website that said that I think URAC said they could accredit dental. What's the industry standard today? And is Delta Dental accredited?
No, accreditation standards have not been developed for dental plans. It is true that URAC and NCQA say that they can do it. It certainly is possible, but you have to develop all of the standards. It's a very costly exercise. The dental industry is not opposed to it. It's really a matter of getting kind of a movement afoot that says it's worth the expense, that the benefit of accreditation of dental is seen to be of such benefit, and start the process. My understanding it is like a 2-year process to get committees pulled together, establish the standards, put the plans through the process, etc. But none exist today.
Do you have any kind of quality procedures, or are there any kind of industry standards that apply to this issue? So maybe not accreditation, but there is something else that perhaps the industry does to make sure that there's quality standards met?
I can't think of very much on the national front. I would say the National Association of Insurance Commissioners have a lot of model law and regulations. There are various state rules and requirements around the expectations for dental in terms of quality. I'm most familiar with California, and we have to meet a fairly high bar of rules established by the Department of Managed Healthcare around quality. So they exist, but I don't know that it is at a national level like these accreditation standards are.
So, Madam Chair, I'd like to come back with the state requirements and Nevada state law
Okay,
in the next meeting for this one.
Let's pull this one in too. It's the
Accreditation.
fourth accreditation. I think. Okay, we need to be done by noon.
This one's really short.
Yeah, and I think we need to take a little break too. I'm seeing some people that, you want to take a 2 or 3 minute break and then we'll come back to this? You need- Oh, no, that's all right.
All right, so we'll reconvene at 11:25.
Oh, is that it? I wasn't watching. I'm good right now, so.
Everybody else. All right, let's go back on the record, please. Now we're looking at page 9. I didn't see anything that we were pulling off of page 9 for further discussion. And then,
I would like to just be clear on that last item where we said the dental plan needs to give us 6 months notification. I'm not sure what the requirement is with the state of Nevada laws, but a standalone vision product that withdraws from the exchange can have a significant impact on the exchange, because if they're the only one that provides a standalone dental product, I think I said vision, I meant dental. If they're the only ones that provide a standalone dental product, then all of the medical QHPs will be required to get coverage for dental. So that is a significant issue, and 6 months may actually be even too short. It might really need to be 9 months. If I could get a comment from Mr. Mullins on that one.
See, that'd be something I would agree with that covering.
I don't think that we would be opposed to that. Hopefully, we're not the only standalone dental plan on the exchange.
Can you hear us in Las Vegas?
Yes, we can.
Yes.
Okay, thank you.
We just chose to continue our break for a few minutes longer.
Okay, all right. So be it. All right, so then you want to pull this one just for,
We're going to clarify this with the DOI before for the next meeting.
okay. All right, and then page 10, I don't have any further questions marked on mine or on page 11.
I think page 11 we need to, this is part of the splitting out of pediatric versus adult dental that will come back, put all these side by side. So I think what I envision going forward for this, for the next time, is to provide the same table. We will probably have to provide it in landscape rather than portrait mode to be able to fit all the columns on it, but we'll include 2 columns for dental, one for pediatric and one for adult. We will pull all the ones that we have just discussed as a separate block. We will include all the ones that we haven't pulled just so that we have a full report, but we won't change them. But we will still split them out by pediatric and adult dental, just so that everybody's clear. We have a full report for the board to discuss.
Then do we want to go ahead and move on those items that we don't pull, or do you want to wait?
I think we can wait on those ones, so we have the full report. I would like to have a quick discussion on the max benefit versus out-of-pocket maximum. And that's part of the reason why we need to pull this last one. This says that the pediatric essential benefit be covered without any lifetime dollar limit. And I think Mr. Mullins talked about having an adult benefit that had a benefit maximum. And do you see that going forward? Or would you see the adult programs conforming with the pediatric programs, or is it going to be a market condition and we'll see what happens?
I think today we would say that the rules apply to the essential health benefit, and for whatever reason, Congress decided that the essential health benefit should only cover pediatric dental and vision. So no annual limits on those benefits for pediatric up to whatever that age is. Anyone above that age would have a product or a benefit level that would have annual limits, but they wouldn't have an out-of-pocket maximum because that doesn't apply. So those things would be separated out between pediatric. Now, I agree, market forces, essential health benefit is going to be reevaluated by HHS in 2016. There may be a movement afoot to say that it makes sense, and if that is the case, we would not be opposed to that. I mean, the downstream effect is that it impacts cost. No annual limits increases the cost of a dental plan quite a lot. The purpose of keeping dental products at an affordable level is so that they are purchased and people have the benefit, because the benefit is so tied to diagnostic and preventive. In my experience, in my own family, we have much more dental expenses than we have medical, knock on wood. But that's because the the dental benefit encourages, and your dentist, chases after you to say, well, I want to see you twice a year for a cleaning and x-rays and all of the rest. So the predominance of the dental benefit is to encourage the diagnostic and preventive so that the major and restorative services aren't needed. Now they're there because anything can happen, but that's why the benefit is priced lowly, low benefit levels, priced lowly so that it is purchased at a higher rate. Once you start taking away things like annual limits, that changes that dynamic.
Madam Chair, would this be the only product on the exchange that would have an annual limit?
perhaps the vision product would also, the standalone vision for adult, could also have an annual limit as well.
And doesn't that kind of go contrary to some of the underlying rationale for the ACA?
But it's
No, I
a,
think
it's a fortune, that's what he's trying to
Yeah,
tell you.
I think that's what he just
You
said.
know, I think, have you looked actuarially at whatever your plan design is for pediatrics to try to give us a magnitude, a multiplier of where the rates would be for the 75% one, just as a ballpark?
I don't think that we have it like ready. I can't speak to it as what the price differential is, but it's something that we could certainly come up with. I mean, there's a lot of different standards here because we also have an AV, that dental doesn't have AV today, and there's no out-of-pocket maximum today. It's a very different benefit. I would also add that I think a medical plan that offers any benefits that are in addition to essential health benefits could impose an annual limit on those benefits, if my understanding of the law is correct. So it wouldn't be just dental or vision, could be some medical benefits.
Madam
don't
Chair,
wanna
I think
dis-
that,
I
I
don't
think that
want-
that's still up to question, is
Yeah.
my understanding.
I don't want to discourage this conversation, but we are on a limited time frame here, and we need to move on to another agenda item. If there are additional topics that you want covered, why don't you contact or email me, and we'll get them on the agenda for the next meeting, so that we wrap this up on this agenda item for today. So, we won't call for a motion on agenda item number 4. We'll wait for the follow-up, separating out pediatric from adult care on dental and vision. And move on to agenda item number 5, which is to align service areas with rating areas that have been established by the Division of Insurance. And then if Mr. King wants to come forward, I know we'll have questions for you.
Again, my name's Damon Haycock for the record, and the Affordable Care Act regulations mandate that the exchange must have a process to establish or evaluate the service areas of QHPs to ensure that they meet some minimum criteria. The geographical area, that is at least the entire geographical area of a county or a group of counties defined by the exchange, as well as that they are established without regard to racial, ethnic, language, health status related factors specified, and exclude specific high utilizing, high cost, or medically or that they or other factors that exclude specific high utilizing, high cost, or medically underserved populations. Undeserved would be unfortunate. There was some additional further federal guidance from CSIO that CSIO recommends to align the QHP service areas with rating areas established by the state, that it would facilitate consumers' ability to compare premiums of QHPs and also promote competition. Additionally, it'll simplify consumer understanding and the exchange administration of eligibility determinations for those premium tax credits. Finally, the Nevada state law that governs the exchange, in a nutshell, says that nothing in the law for the exchange can preempt or supersede the authority of the commissioner to regulate the business of insurance within the state, and that the Commissioner of Insurance has the power to establish geographical service areas and establishment of rates within those areas. On page 3 of the report shows the established rating areas from the Division of Insurance for 2014. And there are 4 of them. Clark County plus Pahrump is the first, Washoe County the second, the third, Carson City, Lyon, Douglas, and Story counties combined together, and the 4th is all other outlying counties. So our recommendation is that we do align the service areas for qualified health plans with the rating areas developed by the Division of Insurance.
And just to clarify, this kind of goes along with the network adequacy issue. We have discussed the fact that we would prefer if network adequacy were the same both inside and outside the exchange to make sure that there's a level playing field. Because we have set that as one of our goals to maintain this level playing field and to prevent adverse selection, we said that the Commissioner of Insurance should establish those network adequacy standards. The same goes for the service areas. While the federal law requires that the exchange set service areas, state law says that the commissioner will set rating and service areas. And we also believe that if there's a standard rating area both inside the exchange, there should also be a standard service areas both inside the exchange. We don't want to have an unlevel playing field both inside and outside the exchange. My understanding, and Mr. King can speak for the Division of Insurance, that their intention is to align those areas, and that is our recommendation. But I'd like to hear from Mr. King first.
Thank you. Cliff King, Division of Insurance. Just so you know, these are our proposed rating territories. They have not been sanctioned or approved by CCIO yet. We have to submit these as part of the comments to the rule that was issued a while back, and that time is coming very close now. But we were told that we were to submit them. Did we violate any of the guides? Yes, actually we did. As long as we have 7 or fewer rating areas, they should be okay, but they could be clumped by counties or by first 3-digit zip code. Pahrump does not fall within that guideline. But when you take a look at our competitive market today, the marketplace today, we look at all of our carriers, and all of our carriers use either 2, 3, or 4 rating territories in Nevada. And frankly, those carriers that use 2, they would be able to use the same rate adjustment factor for 2 territories to bring these 4 down to 2 if they chose to do. They could do it with one single rating factor. It gives flexibility to our carriers to be able to use these 4. From a practical standpoint, it makes sense to include Pahrump, which is in Nye County, in with Clark County. And for that reason, we pulled it out. It's about 40 miles or so outside of Las Vegas. But it doesn't match with following the criteria of lumping with counties and first 3 digits of the zip code. So until this is sanctioned by CCIO, this is our proposed rating territories. And we also agree that from the standpoint of aligning territories and the adequacy situation, we have a real concern that PPO adequacy in rural Nevada can be a real problem. And if we mandate that every carrier selling in rural Nevada has to have an adequate network, we may not have any carriers. It's a real problem. I'm not sure how you mandate that a carrier go into Elko, Winnemucca, Ely, and Austin and be able to create an adequate network. It just may not be feasible. So, while a qualified health plan mandates that you have an adequate network, a non-qualified health plan does not. And a non-qualified health plan can be sold outside of the exchange, but not inside the exchange. So it's a dilemma that we're not the only ones faced with this. All the western states that have these big rural areas have the same issue, and it has not been finalized yet. So we're still talking with CCIO about this.
Mr. King, if I might, I'm going to ask you a question. You may not have it, and if you do have, if you can find it out and send it to us, I'd be appreciative. But in your rating area number 4, which is our rural area,
yes,
if you combine those counties together, do you know what the population is of those counties?
We can find out.
It's
let's
not very high, I know.
No,
You've got 2 million down in Clark County, and then.
Well, when you take a look at some of our statutes that we have in Nevada, and it applies to counties with a population in excess of 50,000, for example, and there's statutes that do that, and there's really only Washoe and Clark that apply to most of those statutes that are written in that manner. Now, Carson for a while, but I understand it's fallen down below 50,000 now. But it is a very small area, and there's a few carriers that, when you take a look at area code 3, 3 is really Carson, Douglas, Lyon, and Story counties. And that little area kind of is by itself, and for that reason, carriers have chosen to treat those counties together as one. and we followed their recommendation. However, if a carrier chose that, for example, Story County, to use a 100 rating factor for Territory 3, they would have to do all of Territory 3, but they could do that the same as Washoe if they chose to do so, or they could do it the same as Territory 4, they could do so. We tried to give our carriers flexibility to encourage competition.
Thank you.
Here's a quick, Ron Klein, if I can ask a quick question. I appreciate the difficulty in network adequacy in the rural counties. How do you distinguish between a carrier that is trying to build an adequate network but can't because of a lack of physicians, and a carrier that chooses not to contract with certain physicians even though they're present in the area?
That is a dilemma that we run into, not just in the rural areas. We've had that dilemma in northern Nevada. And it's where there's a very limited number of doctors in a particular specialty, oncology, for example, that choose not to contract with anybody. We've got a dental firm, picking on the dentist here today, here in Carson City that we received complaints on, that when I contacted the dental office, they say, we do not contract with anybody, we're not on anybody's preferred list, we're not going to be, because we're not going to let an insurance company tell us how to operate our business or how we can charge. You know, and sometimes you run into this. And
Well, I mean the opposite. I mean the opposite of what you're saying. I'm not talking about a medical practice. I mean, and I guess it's always a negotiation as to how much you charge and how much you're paid. But I'm not speaking so much about a medical practice that says we're not going to contract with anybody. I mean an insurance company, you know, pick on the carriers rather than the providers, that says, you know, we're going to pay you 50% of Medicare, and the person says, no, I'm not going to accept that. And you know, how do you distinguish that carrier that doesn't have a adequate network because it's offering rates that are too low versus one that's trying to be reasonable but can't? Because those are two very different questions.
yes, and we also encountered that one. And our question to that carrier when that comes up is, other carriers are in the area, have an adequate network, why don't you?
You know, Mr. King and Dr. Klein, I think the issue before us today is whether or not we agree with the recommendation that our service areas align with the rating areas of Division of Insurance. And if I might just bring us back to the topic so that we can see if this committee thinks that's a good idea, so we can take it on up to the board. And Mr. Hager?
I'd like to make one clarification to this. So, as Mr. King indicated, these have not been approved by CSIO yet. So what I would like to say is align the service areas for QHPs with the rating areas approved by CSIO, and then bring that back to the board once those have been approved to confirm that they match what we have here. Does that make sense?
I'll move that we adopt that recommendation, or make that recommendation to the board.
Second.
Okay, I'll call for the vote. All those in favor?
Aye.
Any opposed? Thank you very much. Thank you.
And before Mr. King leaves, just to be clear, is it the DOI's position that the service areas align with the rating areas?
Yes.
Excellent, thank you.
All right, next item is agenda item number 6, possible dates and times and agenda items for further meetings. I think we already know off of the standalone programs for dental and vision, we will bring that back. If there's anything else that members would like to discuss, if you think of something after the close of this meeting, if you'll get in touch with me or Mr. Hager, we'll be glad to add it to the agenda of the next meeting. But do you have a time frame for us?
We need to have time to prepare for the next meeting, but we don't want to make it too far out, so I think we should assume a late February meeting. I think it's about a month. So Athena will be sending out an email, if she hasn't already gotten, I don't think we have anything for February yet. So she'll send out an email either today or tomorrow. Please respond as quickly as possible so we can get it on everybody's calendar before your very busy schedules fill up.
And could I suggest, Madam Chair, that maybe a little follow-up of some information on the presentation we had earlier on mental and behavioral health disparity issue, and just so that we can close that discussion. Because it was just a public comment, and I think maybe we ought to at least talk about it.
We can do that. That is a question of essential health benefits.
Right.
So you want a presentation on the essential health benefits?
Our written report, just putting into context what the public comment was, because it was fairly detailed set of concerns.
Okay, we'll do that.
That may be more appropriate for the board, but I think maybe it'd be useful to pass it through this week.
Okay, any other comments? All right, we're back at public comment again. Do we have any public comment in Las Vegas?
See none.
Thank you. Any public comment here in Carson City? Thank you. And how about on the telephone? Hearing none, I want to thank everyone for their preparation today, and thank everyone from the general public for your comments and your assistance in going through this committee work today. And with that, we will adjourn. Thank you.
Yeah, I know. I thought about this.
I thought we were going to
A lot of detail.
Oh, no, I mean,